you for your patience while we pull this thing together. So I live on the west coast of Canada in Vancouver Island, and I'm a professor emeritus at UBC, which is the University of British Columbia in Vancouver. I'm a pathological paddler, if you will. I have a PhD in exercise physiology, medical degree, and I've been a sport medicine physician for about 40 years, splitting my time between clinical practice and also research, do a fair amount of research. So I'm going to cut through a whole bunch of things because there's a few take-home messages I'd like to share with you tonight, and I'm not exactly sure how much time we have, but basically, I'm going to talk a little bit about how all this started, and then I'm going to run through what happened over the last 30 years. And then I wanted to talk to you about some new things in exercise oncology that I think are going to change the landscape for treatment of breast cancer, at least. So the way this all started was, a breast in a boat. That was a long, long time ago, 30 years ago. And it was this woman who showed up. We have a referral-based large academic medical clinic on the campus. And there was a 55-year-old woman who came to see me, referred because she had shoulder pain. And she was fit looking, and it was her left shoulder. She had breast cancer on the right side a year or two before. And we went through the whole process as we would clinically. And basically, she had a fairly straightforward rotator cuff problem. The advice to her was, we need to do some exercises to get this better. You don't need surgery or anything too fancy. And she said to me, I can't exercise because I've had breast cancer. I'm not allowed to lift weights. I'm not allowed to do strenuous activities. So, what do we do now? And that really is what started this. The first year that we did this, which is 1996, it was not about canoeing per se. It was actually about breast cancer-related lymphedema, because that was the fear at that time, and also women's health. If you're a breast cancer patient at that time, you weren't allowed to do very much. It limited your lifestyle considerably. And if you're limiting your lifestyle in terms of exercise, then you're affecting, a whole bunch of different things. So at that point in time, I thought, well, my job will be to, as a researcher and exercise person, is to start a research program on exercise and lymphedema, because they didn't know very much about that. And then also find a visible representation of the research program. In other words, if you're a breast cancer survivor and you're told not to do vigorous, strenuous exercise, find something that is vigorous and strenuous, that is a visible challenge, if you will, to traditional medicine. And so that's where a breast in a boat came in, and dragon boating came in. And I won't dwell on all the positive things about dragon boating. I will say that we spent a lot of time, and I had two PhD students do a lot of work on lymphedema and exercise, and we ended up using radioisotopes and tracking the lymph tissue or the lymph movement within the lymph vessels. We created something called a lymphatic stress test, which is similar to an exercise stress test for cardiac patients. In any case, dragon boating was the strenuous, repetitive upper body activity. And the feeling was, if you can do that and not develop lymphedema, well, maybe we've made a statement about the mechanisms of support of lymphedema. So dragon boat, this is the original crew in our first race, actually. It's back when we had long sleeve cotton, very heavy shirts to wear. That also led to the development of the original Breast in the Boat team. And the young woman at the very bottom of that slide is actually Jane Frost. And some of you may have come across Jane Frost. She was the first president of the IBCPC, a wonderful woman. This woman sitting now in the back, hanging out, is Esther. Esther is still in that seat 31 years later. She hasn't moved very much, nor has this woman over here. So a Breast in the Boat, we have teams, 6 or 7 teams within the greater Vancouver area. The accomplishment this year one really was increased breast cancer awareness. And you don't need much of that anymore, but certainly back in 1995, 1996, you did. We were able to challenge the myth that breast cancer-related lymphedema was not caused by exercise or was caused by exercise. We showed that breast cancer survivors could lead full and active life. You can pick up your grandchildren, so you can go back to playing tennis and golf and some of the fun things that are useful. And also, we ran this program out of a place called the False Creek Racing Canoe Club, which tends to be a pretty high profile canoe club and dragon boat and outrigger, but also sprint as well. And some very, all a bunch of Olympians that kind of hang out there. And I must say that Olympic group, really respected the first year dragon boat paddlers because they really were athletes. They were working just as hard as a lot of the people who were not quite professional, but certainly involved in high level sport. And so, the women from day one gained the support of the rest of the canoe world. What happened over the next 30 years? Well, very, very quickly, growth. So we started with one team. 1996, there was one breast cancer dragon boat team. This is just a quick slide of things that have happened. In South America, in 2014, there were no teams. Now there's about 50 teams. Before I got on our email here tonight, or Zoom call tonight, I spoke to a team in Santiago. This weekend, there's a huge, huge being 11 breast cancer teams from South America are together for a 3-day event. It's their third annual dragon boat event in South America. A number of groups of people decided that if those women can do it, then we can do it as well. So there's a whole bunch of clinical groups, if you will, pediatric oncology, people with renal disease, the multiple sclerosis people, the visually impaired, solid organ transplant. We have had, Barb, people that have had heart and lung transplants, usually from cystic fibrosis, and still get in the dragon boat. So, it's possible to kind of overcome some fairly aggressive treatments and still get back in the boat. Prostate cancer, of course, breast cancer teams now are worldwide, 6 continents, thousands of women, hundreds of locations. It's been quite a movement over the last 30 years. Some of you have participated in these events, and that happened to be the one I think, Barbie, recognize that might be the same shot from the other side of the river, actually. I'm not sure, but that's Italy. Some of you have been to the big festival in Sarasota, which was extraordinary from my perspective. It was Kim Bonomo down in Sarasota put that one on, and it really opened the door, I think, at least in America, North America, to facilitate these types of activities for cancer survivors. And there's a tremendous media explosion, actually. About 2 or 3 years after we started, oncologist phoned me up and she said, what are you doing? What kind of things are you doing with this dragon boat program? And when we first started, some of those calls were not the most fun-like ones because there was quite a bit of criticism and speculation about outcome before we actually got some data to show people. But in this case, it was one of the female oncologists who deals with the cancer patients, the breast cancer patients, and she was wondering that the patients that are involved in the dragon boat, they're all happy, they all have smiles, they all look fit, they sleep at night. So maybe we should get together and do some supervised exercise programs. And that's when we got involved with a number of individuals, one being a fellow named Kerry Corneille, who I'll get back to in a few minutes. And we had multi-center trials across Canada, big multi-million-dollar trials in a place like the gym where we're doing supervised exercise during chemotherapy. And so this is the type of place that we have. And it's changed a little bit, as Barb was alluding to. This is very labor intensive to have individuals come, and we're measuring heart rate, and we're looking at weight training, we're doing a bunch of stuff. And it would make so much more sense, and in some ways we're moving in that direction by using some of the wearable things that Barbara was talking to you about. So the future really is not so much adamantly supervising programs, but actually wearing devices that will collect somewhat similar information. My son is a PhD in big data stuff as well, and he and I have been working on some projects where you look at data from thousands of individuals, and you really can tell a story. You don't know very much about each one, but you get a nice clear picture if you have the large enough N. In Vancouver at that time, still to some degree, we actually had a program. Socialized medicine means it's paid for by the government. In this case, your oncologist recommends exercise and nutrition information. So this was the type of programs we would have. Once you had the diagnosis of breast cancer, you would see your oncologist. The oncologist would see you for the first time before chemotherapy. They would check off any sort of the medical history that might be of interest, heart disease, arthritis, what have you. And then you'd come out to the sports medicine clinic. And we would put you through a whole bunch of tests, and then we would put you back into that cancer gym and follow you throughout the course of your chemotherapy and sometimes radiation. And they were very, very, very popular studies by the women with breast cancer because the attention that they were getting. And we had people who hated to actually leave the gym at the end of the sessions. In fact, they created quite an alumni group. And the alumni group would be the people who would be organizing breast cancer survivors to participate in the fun runs and developing T-shirts and what have you. But that was a very positive thing to have. And this is what we learned. If you came to the gym during chemotherapy, and these are 2, 3, 4 months, you're there in the gym 3 days a week. And if you stay there and you'd work at it, and we had, for most of our things, over a 90% adherence rate, then you had less fatigue, fewer hospitalizations, fewer problems with your white cells, decreased pain, certainly improvement in terms of psychological health. The immune function I have increased, but I'm not 100%, should have increased, but it's hard to say because of what's going on with chemotherapy. You basically maintain your fitness, aerobic fitness. It's hard to increase your aerobic fitness when you're getting chemotherapy because you're losing red cells and you become slightly anemic. You certainly can maintain your muscle bulk with weightlifting, and your bone health stays nicely positive because of the things you're doing. And in fact, the bone health exercise for bone health is, of course, critical during chemotherapy because a lot of chemotherapy actually leaches calcium from your bones. People would have better sleep. And in one study, we actually showed increased chemotherapy completion rate, which we haven't been able to reproduce. But that as you probably know, is an important variable when you're being treated for breast cancer. The outreach programs have been extraordinarily popular. So the one on the left was Brazil. The one on the right was from Colombia. This is one from Argentina. And the majority of the women, those are the ones actually today that are actually over in Santiago at the big festival. And we would bring these women together, and they don't know anything about dragon boating. We'd put them in chairs, and we'd try and teach them a little bit about stroke mechanics and what have you. And then we'd take them outside the tent. There's 2 dragon boats. They're on the water. They're paddling, and they're quite a lot of fun. I was in Hungary 2 weeks ago, starting another team down in a place called Szeged. And it was quite a remarkable spot. I know Hungary quite well because it's a canoeing mecca for the Olympics. And if you're the best, if you're on the national canoe team, then you're the same as Tom Brady and some of those people. I mean, you're a special person. They had a site for training that would put shame to anything in North America in any case, simply for canoeing. But it took them 30 years before they started a breast cancer dragon boat team in a place like Hungary. And there's still lots of places that need the outreach programs. And that's what basically I've been doing now for some time. How about some exercise oncology? And this is where there's some big changes. And I just want to make sure you probably are aware of most of the stuff. But I think the door is really going to open soon to advances in exercise in the oncology world. And it's important because it makes such a difference. And people have, 30 years ago, they dismissed exercise. We have a hard time still getting the medical profession to buy into exercise as a positive and important intervention. But right now, through the literature, it's pretty easy to establish exercise as a supportive care intervention. Improves quality of life. It helps with your symptoms, as I've noted. Your psychosocial benefits are present. It's useful before in terms of prevention, during, while you're being treated, and post-treatment for breast cancer. And we've used it across all disease stages up to and including metastatic disease. Now, what was interesting is, why did it take so long to develop exercise guidelines? We've had them in cardiac rehabilitation for 70 years, not in cancer. And that's because traditional medicine says you've got cancer, time to rest, time to take it out, allow yourself to heal. And fortunately now we've kind of seen that's not the best guidelines for everybody. And then we need to have others. Most of you have probably seen these guidelines. These are from the American College of Sports Medicine. They're quite useful. One thing that you will notice when you spend some time looking at them, first of all, they only came out 10 or so years ago. Second thing is there's no specificity to it. Everybody's supposed to be doing 150 minutes worth of exercise. We want you to go to the gym a couple times a week as well, do some stretches, what have you. It lacks specificity, and it probably does that for a reason. This is a very important paper by Anne McKenzie, who happens to be just down the streets in Seattle from where I live, across the border in Canada. And that's looking at the relationship between physical activity and mortality in cancer survivors. And unfortunately, I can't see all of the, there it is. What this is showing, of course, in terms of cancer-specific mortality for breast cancer, the relative risk reduction by doing a couple of hours of exercise a week is a reduction of 38% of cancer-specific mortality. In terms of all-cause mortality, the approximate relative risk reduction in breast cancer is 48%. And that just kind of emphasizes the benefits that exercise plays, not just for cancer, but in heart disease and diabetes and hypertension and a number of things that I'm sure you're all aware of. Whoa, maybe I need to do this. Now I've lost the ability to move this. Oh, maybe that'll do it. Okay. One of the really important things that happened 2 years ago was that the American Society of Clinical Oncologists reviewed all the literature and came up with guidelines. And that is huge because the sport people, the exercise people, the fitness people can talk all they want. But when your oncologist says to you, yeah, we've had a look at this and we are now recommending aerobic and resistance exercise from your oncologist. We want it during active treatment to mitigate the side effects of cancer treatment. And it's going to do the same things I was talking about, reducing fatigue, improving strength and fitness, quality of life, etc. But what the oncologist said at that time was that the clinical benefits to influence cancer outcomes are insufficient. In other words, you're going to feel a bit better. It'll help you, but it's not going to affect your outcome. And so, first of all, that's the first step is huge because when oncologists recommend things, people are more likely to listen. If it's coming through a hospital and the oncologist said, we really should be doing some exercise, there's sort of some acceptance of, well, maybe we better put together some programs so we can actually do what the oncologists want us to do. If they ask us to buy chemotherapy drugs and do surgery and targeted therapy, we do that for them. And now they're asking for exercise. Let's find a way so that patients going through chemotherapy, heading towards radiation, other types of treatment, have the advantage of doing exercise because it's going to make a difference to them. Oops. Whoa. Now, two studies I want to talk to you about very, very briefly. First one was done in Canada by Corneille, and this is one of his grad students. We worked together there quite a bit. It was a group of rectal cancer patients, only 36 people, and they all had rectal cancer, and they were undergoing neoadjuvant treatment. So they were going to get treatment, and then they were going to go to surgery for their rectal cancer. 36 of them were divided into two groups. They were all getting chemotherapy radiation for 6 weeks. Then they were taking 6 weeks away to recover from the chemo radiation, and then they're going to surgery. Half of them for 12 weeks then did high intensity interval training, a type of training where you're doing 2 minutes walking briskly at 85% of your VO2 max and 2 minutes at 40%. So high intensity, easy. High intensity, easy. They started off by doing that 3 times a week, and each session was 5 times that hit. That gradually increased. Other group just did the usual care. In other words, were not incorporated in with any high intensity exercise program. And so at the end of the 12 weeks, they went to surgery, and 10 of the 18 people who did the exercise didn't require any surgery. Like the cancer treatment plus exercise virtually cured the rectal cancer of 10 of these individuals. Now, chemotherapy radiation will cure some diseases in conditions, and the usual care program is 3 out of 17 actually required no surgery. So exercise is now making a meaningful difference as you've moved forward. Another study was actually on breast cancer, neoadjuvant treatment. This was actually with some of you may have heard of Melinda Irwin at Yale University. She's an exercise oncologist, a lovely woman. And this was a group of 72 women who were undergoing chemotherapy, and they were doing the standard exercise program, 150 minutes a week, plus a bit of weightlifting. When they went and they completed that during chemotherapy, and then they went to surgery, 53% had pathological complete recovery. What that means is they looked at the specimens under a microscope and could not find any cancer. Of the usual control group, 28%. So again, showing the very positive effect when you combine exercise, in this case with chemotherapy radiation. Now the big one is this. It's called the challenge trial. I'm going to put up the reference for this, and I really would encourage you to have a look at the challenge trial. Challenge trial is a 3-year structured exercise program for patients with colon cancer. And they were given exercise. Half of them received exercise, half of them received an educational booklet. Bottom line is the relative risk of disease recurrence, new primary cancer, or death was decreased by 28%. Now, this is the reference, New England Journal of Medicine, June of this year. It's only 3 or 4 months old. So you can look that up. And the key author is a fellow named Kerry Corneille. He's a Canada Research Chair at Alberta. And it's called Structured Exercise After Adjuvant Chemotherapy for Colon Cancer. Almost 900 patients, 55 centers globally. Most of them were in Canada, Australia, the UK, and France. And I still don't know why the United States was not, I'm sure they were invited, but I'm not sure why they did not participate. But in any case, 900 people, half of them were randomized to what's called a structured exercise group for 3 years. And the structured exercise group was you actually had interface with a healthcare professional experienced in prescribing and maintaining exercise. It was only every few weeks and then every few months, but it continued for 3 years. The end point was disease-free survival. And at the end of 8 years, and after, 8-year overall survival was 90% in the exercise group and 83% in the health education group. This was presented at the American Society of Clinical Oncology meeting in Chicago a few months ago. And when these trials came out, this data was presented, received a standing ovation from the oncologists, that's just the exercise people. So that was big news. But this is a slide from that presentation. And this puts everything into context. This is putting effect size into context. And if you look at adjuvant exercise, that means exercise after you've been treated for your disease, the absolute overall survival is 7% at 8 years. Well, what about this drug? Same drug used in those patients. Well, it's 5% 10 years. These are all lung cancer. This is a breast. This is the type of numbers you see when they put it into context. 5% increase in survival at 5 years, or 5%, 7% at 8 years with the people who are doing exercise. So in other words, exercise, at least on face value, is as good as chemotherapy. So what happened in Canada, the oncology people who deal with colon cancer came back to Vancouver, and next thing we know, we are getting a phone call saying, how are we going to implement this program? Because what that data means is this: exercise is standard of care. I've pushed that for 10 years to all oncologists I could find. They're lovely, lovely people. They're all saints as far as I can see. But getting them to accept that exercise is as good as chemotherapy, is as good, as important for many reasons as a lot of the other things that we do. And the exercise could be breast cancer, dragon boat paddling. It could be the cancer gym. But if it's standard of care, so now the oncologists are coming to the exercise people, which never used to happen, and saying, help us develop exercise because we don't know anything about it, but we now understand the importance of it. So look that paper up because and have a good read through it. It's a compelling argument. Very briefly, I'm just going to lay this out, and then we can talk a little bit but what's next in exercise oncology? Well, from my perspective, we have exercise, and the huge issue now is going to be specificity. Now that we know that exercise improves survival, what type of exercise? Aerobic, resistance, combination. When do you prescribe it? At what point in treatment? Or should everybody be doing exercise? And also nutrition, not just simply from the straightforward nutrition, but actually looking at intermittent fasting, because I've been using that in some of my breast cancer patients, and it really makes a difference for the healthy breast cancer patient during exercise. It's something else that they have control over. And there actually are clinical trials that are just starting in America and some in Canada, looking at exercise plus what you eat, when you eat, and also the relationship to when you exercise. So people are going through these windows where you finish dinner at 8 o'clock night and you don't eat anything again until noon the next day. So you have a 8-hour window of eating and a 16-hour window of intermittent fasting. It's debated. There's things that need to be looked at. The other thing is there's a lot to be learned from athletes who challenge the limits of human performance. And I've been to 10 Olympic Games. I coached at a bunch of them, and if we had some time, the people who are challenging the limits of human performance take things very, very seriously. And if we had time, we could talk about some amazingly innovative strategies when you're looking for half a second over 500 meters in a kayak paddle, right? And the physical and mental components of performance. And as Barb suggested, and I agree, monitoring devices are now really important because you need that level of precision. If you're going to say exercise is good for me, then you really owe it to yourself to say, well, at least when I do the exercise, I need to make sure I get that bang for my buck. Is the exercise prescribed that I'm doing, is that the thing I should be doing? Is that going to make a big difference to my overall health? Is that going to improve my survival? So, these are people that are challenging the limits of human performance. So this is a young Canadian woman, and this is another young fellow that actually he's the minister of sport in their government right now. So she has 3 Olympic medals. He has 4. Going to the Olympics isn't a whole lot of fun, but it's a very driven, precise thing. But quite frankly, this is the first year abreast in a boat. They had to go through a whole lot more before they got on the water than these guys did. And they too challenged the limits of human performance. I can't tell you how much admiration I have for the original group and actually everyone who says, I'm going to pick up a paddle and get on the water and do what's good for me. So again, this is Adam Van Koeveren, Olympic medalist, Olympic champion. This is old data, but this is the type of thing that you would see on him. And I would click on that variable, and it would give me his heart rate and his velocity and where he, And you use that a lot. You use that because if he's supposed to do 10 times 1,000 meters at a certain intensity, then I can look at the heart rate and say, okay, Adam, looks to me like today's interval number 7 and 8, you didn't go hard enough, or you didn't rest long enough between intervals, whatever. But I've taken that, and this is for many years, and this is a lymphoma patient. That lymphoma patient wants to know what they should do. There happens to be spring, they're doing some cross-country skiing and then on some indoor cycling. So technology that Barbara was describing is the future. We are going to be using this more and more and more, unfortunately, because we're going to have more and more and more cancer patients as we all get a bit older, and immigration changes things. And that's where I go paddling mostly. So it's across the road here. So in any case, thank you very much for tolerating that. And if there's any questions or comments or suggestions, the take-home message is that we now know the importance of exercise. It's been proven. The oncologists know it. Yes, we have to do these studies again in cancer, other breast cancer, or in breast cancer patients, leukemia patients, what have you. But the fact now we've opened the door, the importance of exercise, now it's up to us as the fitness people to be able to deliver it.
Thank you, Don.